Definition: atrioventricular septal defects are characterized by a deficiency or absence of septal tissue immediately above or below the normal level of the atrioventricular valves, including the region normally occupied by the atrioventricular septum in hearts with two ventricles. The atrioventricular valves are abnormal to a varying degree. These defects are also known as endocardial cushion defects, ostium primum atrial septal defects when there is no intraventricular communication, and common atrioventricular orifice when there is only a single atrioventricular orifice. History: Roger and Edwards recognized the morphology of primum ASD to be similar to that of the atrioventricular septal defects in 1948. Wakai and Edwards termed the partial or complete AV canal defects in 1956. Bharati and Leff termed transitional intermediate in 1980. Leff described the position of the atrioventricular node and bundle of His in these malformations. Rastelli described the common anterior leaflet in 1961, based on which the Rastelli classification of the atrioventricular septal defects was developed. Lillyhive, the first repair in 1954 using cross circulation was done by Lillyhive. Kirkland, Watkin, and Cross did the first open repair of using oxygenator. Incidence: the complete endocardial cushion defects, also known as AV canal defects, complete AV canal defects, or AV communis, occurs in 2% of all congenital heart diseases. Of patients with complete endocardial cushion defects, about 70% are children with Down syndrome. Of children with Down syndrome, about 40% have congenital heart diseases, and 50% of these defects are endocardial cushion defects. Endocardial cushion defects is also a component of heart defects in asplenia and polysplenia syndromes. Morphology: development of the atrioventricular canal. It includes the septation of the common atrioventricular orifice and the closure of the atrial and the ventricular septums. The development begins by the proliferation of the endocardial cushions and the conal cushions. The common atrioventricular orifice is divided by the growth of the superior and inferior endocardial cushions towards each other. The lateral cushions form later. The below picture shows the development of the endocardial cushions, superior endocardial cushions, and the inferior endocardial cushions, and their growth towards each other, dividing it into the left, right, and the left atrioventricular canal. This occurs between 28 to 33 days, 35 days. This is again the picture showing primitive right atrium, the primitive right ventricle, and the primitive left ventricle, with a primary interventricular foramen and the atrioventricular canal. The second picture shows the formation of the endocardial cushions, the superior endocardial cushion, the inferior endocardial cushion, and the two lateral cushions. And also along with that, the right superior and the left inferior truncal swellings, and the right dorsal conal swelling, and the left ventral conal swelling. During further development, there is also formation of the interventricular septum from the base. During 33 days of development, the superior and the inferior interventricular septum, muscular interventricular septum is formed, and after the fusion of the superior and inferior endocardial cushions, the right atrioventricular orifice and the left atrioventricular orifice are separated. And also this picture also shows after the fusion of the truncal swellings and the conal swellings. The above picture shows the superior endocardial cushion or the superior bridging leaflet, the inferior endocardial cushion or the inferior bridging leaflet, and the lateral cushions on the right side is divided into anterior superior leaflet and the right mural leaflet, and the left side it is the left mural leaflet. This part of the superior and inferior bridging leaflet on the left side forms the anterior mitral leaflet. The left mural leaflet forms the posterior mitral leaflet. Whereas the septal leaflet of the tricuspid valve is formed by the inferior cushion, and the anterior leaflet of the tricuspid valve is formed by the superior cushion and the right lateral cushion, which is the anterior superior leaflet. The posterior tricuspid valve is formed by the inferior portion of the right lateral cushion, which is the right mural leaflet. Types of atrioventricular septal defects: it's either partial or complete atrioventricular septal defects. The basic defect in these malformations is deficiency or absence of the atrioventricular septum, resulting in ostium primum defect immediately above the atrioventricular valve, and a deficiency or scooped out area in the inlet basal portion of the ventricular septum immediately below the atrioventricular valve. Partial AV septal defects, It consists of ostium primum ASD, two AV annuli, and the two AV valves. This occurs due to incomplete fusion of the superior and inferior endocardial cushions, resulting in a cleft in the anterior mitral leaflet. Complete AV septal defects, the ostium primum ASD, the large consists of a ostium primum ASD, a large inlet VSD, a single AV valve. The failure of fusion of the superior and inferior cushions resulting in separate anterior and posterior bridging defects along the crest of the ventricular septum. Because of this continuous spectrum of gradations lies between these two extremities, some of them are grouped into intermediate and transitional. This is an image which shows the common atrioventricular valve with a superior bridging leaflet, inferior bridging leaflet, the right anterior superior and the right inferior leaflet, and the left mural leaflet. And because of the failure of fusion of the superior and inferior bridging leaflet, it's the final picture. The image C shows a cleft in the mitral valve, anterior mitral leaflet. Now the atrioventricular septal defects are either partial or complete, and two transitional and intermediate types of AVSD are seen. The differences between these are: in partial, there is a primum ASD and the cleft in the anterior mitral leaflet. In transitional, in addition to the ASD and the cleft in the anterior mitral leaflet, there is a small inlet VSD which is mostly obliterated by the caudal adjustments of the septum. Whereas in intermediate, along with an ASD, primum ASD, there is a large inlet VSD and the common atrioventricular annulus, which is separated by tongue of tissue in the two orifices. Whereas in a complete atrioventricular septal defects, there is a primum ASD, large inlet VSD, and the common atrioventricular valve with 5 leaflets. Partial atrioventricular septal defect, it can be of with an interatrial communication. Usually, when there is an interatrial communication, it is related to the deficiency of the atrioventricular septum, which is so-called ostium primum ASD. The defect, it is bound inferiorly by the displaced atrioventricular leaflets. Both the atrioventricular leaflets are at the same level because of the displacement of the mitral towards the apex, and above by a crescentic ridge of the atrial septum that fuses with the atrioventricular annulus, that is superior bridge of the atrioventricular annulus, only at its extremities. There is a little atrial septal tissue at the superior point of fusion of the atrial septum with the valve annulus adjacent to the aorta, but more tissue is usually present inferiorly adjacent to the coronary sinus. The distance between the crescentic atrial margin of the defect and the atrioventricular valves decides the size of the atrial ASD, which is the interatrial communication. It is usually of moderate size. In most cases, the fossa ovalis is normally formed, and there might be a patent foramen oval or an associated fossa ovalis ASD. In case of a small interatrial septal deficiency, it is restricted to the area normally occupied to the atrioventricular septum. If it becomes small, if it's still smaller due to the fusion of the base of the left superior leaflet and the left inferior leaflet to the edge of the adjacent portion of the atrial septum, it becomes restricted. Rarely, there may be an accessory parachute of fibrous tissue that narrows or obstructs the defect. In such circumstances, a pressure difference exists between the two atria. Common atria is when the atrioventricular septal defects is associated with a patent foramen oval or the absence of entire limbus and fossa ovalis. Whereas the other subtype is absence of the interatrial communication. Rarely, aortic valve tissue is attached completely to the edge of the atrial septum, and no interatrial communication exists despite the deficiency in the septum. In such a variant, usually an inlet VSD of large communicating type is present beneath the attachment of the leaflets. In such cases, the functionality of the left AV valve, consisting only of those portions of the left superior leaflet and the left inferior leaflet on the left side of their attachment to the atrial septum, are tend to be competent. As seen when they are seen from the right atrial approach, the part of the right atrioventricular valve may have caudal attachments across the ventricular defects to the left side of the septum, such that it is straddling. When viewed from the ventricular side, it gives an appearance of a complete atrioventricular septal defect. In partial AV septal defects, ventricular septal deficiency and interventricular communications, usually there is no interventricular communications, but when below the left superior leaflet and the left inferior leaflets, they are usually downwardly displaced onto the crest of the septum throughout its length. So because of that, there is no interventricular communication. Occasionally, a small interventricular communications are present beneath the attachment of the atrioventricular valve to the septum, and a scooped out appearance of the inlet septum is present. And the mitral orifice is usually triangular in shape and has a cleft in the anterior leaflet directed towards the mid portion of the ventricular septum in a partial atrioventricular septal defect. In a complete atrioventricular septal defect, it differs from the partial in the presence of a large ventricular septal defect and a separate left superior leaflet and a left inferior leaflet, and the communication is usually beneath the left superior leaflet for the ventricular septal defect. The deficiency of the inlet portion of the ventricular septum, the scoop, which is also present in the partial, is usually deeper in hearts with complete atrioventricular septal defects than in those with a partial. Uh, Atrioventricular valves, the attachment of the atrioventricular valves to the crust of the ventricular septum in partial atrioventricular septal defects, as well as their caudal attachments to the incomplete atrioventricular defects, are displaced towards the apex of the heart because of the deficiency of the inlet basal portion of the septum. This alters the orientation of the atrioventricular orifices relative to the aortic orifices. That is, the aortic valve is no longer wedged between the atrioventricular valves. This results in a reduced distance between the mitral valve and the apex as compared, that is the inlet portion, whereas compared to the aortic valve and the apex, leading to the narrow LVOT or gooseneck deformity on the left ventriculogram, which is an important imaging criteria for this malformation. This is an image which shows the reduced distance between the inlet portion, that is mitral valve and the apex, and narrow and the long outlet between the aortic valve and the apex, giving a long narrow LVOT and a scooped out appearance of the left ventricular inlet portion of the left ventricular septum. This is a ventriculogram showing the gooseneck deformity of the narrowed LVOT. When two aortic valve orifices are present, as in partial AV septal defects, the left superior leaflet and the left inferior leaflet are joined to a variable extent anteriorly by leaflet tissue near the crust of the intraventricular septum. Together, they resemble an anterior septal leaflet, anterior mitral leaflet with a cleft. But in fact, the left anterior valve is tricuspid and orientally differentiated from the normal valve. The connection between the left superior and the left inferior leaflet may be it is only connected by a thin strand of tissue, but it's usually more commonly deep of 2 to 4 mm, and it is connected to the crust of the ventricular septum defect. Yilmaz and colleagues distinguish between a commissure is usually supported by the caudal apparatus on either side of the cap, whereas a cleft is relatively unsupported and bereft of chordae at its edges. In addition to that, the chordae that originates from the central edges of the left superior leaflet and inferior leaflet attach to different papillary muscles, which causes a distracting force on the leaflets during the closure. Because of this, there usually presents a regurgitation. This contrasts with the normal commissure in which the chordae are usually attached to the adjacent leaflet edges attached to the single papillary muscle, which encourages the coaptation. The left lateral leaflet is usually smaller than the other two leaflets in this type of deformity, and it is triangular in shape. These left AV valve leaflets anomalies may make the valve regurgitant to a variable degree, sometimes severely. When the left superior leaflet and the inferior leaflet are nearly completely separated, an appreciable gap may occur during systole, which produces regurgitation, and the jet is usually directed towards the RA because of the defect of the atrioventricular septum. When there is a failure of valve coaptation at this site, the leaflet tissue forming the margin between the usually becomes thickened and rolled out. In other cases, the regurgitation appears to be deficiency of the leaflet tissue, particularly in the left inferior leaflet. This is an image showing the left superior leaflet and the left inferior leaflet with its attachments to the crust of the ventricular septum. And in the second picture, the arrow mark shows the coaptation, the site of hinge for the left superior and the left inferior leaflets and their attachments to the ventricular septum. And it also shows its attachments to the anterior papillary muscle. If there is a common atrioventricular orifice, such as in a case of complete atrioventricular septal defects, the left superior and inferior leaflets are separate, and a bare area is exposed on the crust of the ventricular septum, as seen in the picture shown beside. There is a inferior leaflet, and the bare area is shown because of the absence of the fusion of left superior leaflet with the ventricular crust. The left superior leaflet, which is the anterior mitral leaflet, may be entirely on the left ventricular side of the septum, or maybe to a variable degree, it may bridge the septum and extend into the right ventricular side. This variability formed the basis for the classification of by Rastelli and colleagues into types A, B, and C. The caudal attachments of the right ventricular extremity of the left superior leaflet vary according to the degree of bridging. In the Rastelli type A classification, there is no bridging, but the caudal attachments are to the ventricular crest. Whereas in type B, there is mild bridging. They are to the papillary muscle in the right ventricle with moderate bridging. In case if there is a moderate bridging, they are attached to an accessory apical papillary muscle. In type C, there is marked bridging and to the normally positioned anterolateral papillary muscle of the right ventricle. And the left superior leaflet, in case of a moderate or markedly bridging that extends into the right ventricle, it is usually not attached to the ventricular crest. In such a case, it is called as a free floating leaflet. But it may occasionally be attached by chordae and tethered. The length of the caudal or fibrous attachments to the right side or the crust of the ventricular septum, it varies according to the size of the intraventricular communication or the position of the leaflet. The left inferior leaflet typically bridges moderately and is attached to the underlying ventricular crest either completely or by short thick chordae with intercaudal spaces, which may form the small interventricular communications. The caudal attachments of the leftward components of the common atrial valve, AV valve, in the left ventricle are usually relatively normal, although the posterior papillary muscle is displaced more laterally than normal and the third papillary muscle might be present because of its tricuspid anatomy. There may be only one papillary muscle, which may producing a parachute type of valve, which is usually difficult to repair and produces a higher post-op mortality rate. The first picture shows the type A Rastelli, in which the left superior leaflet and the right superior bridging leaflet and the caudal attachments of the left superior leaflet to the ventricular crust are seen, and there is no bridging. Whereas in the type B, there is bridging of the left superior leaflet to the right ventricular side, and the caudal attachments of the left superior leaflet are attached to the papillary muscle on the right ventricular side. In type C, there is left superior leaflet is mostly towards the right ventricular side, and there is no attachment of the left superior leaflet with the ventricular crust, which is depicted as S with an arrow mark. When the bridging is absent or mild, the right superior leaflet is large, whereas when there is more extensive bridging because of the uh, movement of the left superior leaflet into the right ventricular side, the right superior leaflet usually tends to be smaller. Accessory orifice, in about 5% of the cases, it is present in the commissure on the left side below the left lateral leaflet, and it is surrounded by a ring of caudal tissue, and beneath it is a papillary muscle is attached. This fibrous tissue bridge between the accessory orifice and the main orifice consists of valvular tissue and chordae. This emphasizes the danger of producing regurgitation by cutting the bridge. This predisposes the patients to stenosis post-repair. Presence of a single papillary muscle, all the chordae of the left AV leaflets insert into the single papillary muscle, which is usually situated anteriorly in the left ventricle. In complete AV septal defects with a free floating and bridging left superior leaflet, there is no left ventricular inflow obstruction, occurs. Otherwise, or after repair, the situation is entirely analogous to a parachute mitral valve, and inflow obstruction can complicate the intracardiac repair. Ventricles, in the severely right dominant type of atrioventricular septal defects, the LV is severely hypoplastic. In such cases, the atrial septum is usually displaced leftward in relation to the plane of the ventricular septum, in which cases it overrides a left atrioventricular valve to a varying degree and may also be associated with the hypoplasia of the left ventricle. The left ventricle or the right ventricle is severely hypoplastic in about 7% of the patients born with complete AV septal defects. That such presence of severe ventricular hypoplasia can increase the risk of surgical correction and may demand a Fontan repair alone or with a technique for correcting the hypoplastic left heart physiology. Septal malalignment, usually two atrioventricular valves or common atrioventricular orifice lies in proper proportion over the two ventricles. When one ventricle is hypoplastic, the ventricular septum is malaligned and lies more towards the side of the hypoplastic ventricle. When this is severe, both the AV valves or the common AV orifice are accessible only from the right atrium, and the blood exists from the left atrium only through the septal defect, which is the ostium primum defect. Such an defect is called as a double outlet right atrium. Uh, left ventricular inflow or outflow tract obstructions usually occurs in 1% of cases in the preoperative period, but it is the most common. It becomes most prominent in the postoperative period. The anterolateral muscle bundle of the left ventricle, which is called the muscle of Mollard, bulges into the left ventricle outflow tracts in hearts with atrioventricular septal defects than in normal hearts. This contributes to the tendency of outflow obstruction after repair. The presence of discrete subaortic stenosis or presence of excrescences of AV valve tissues heaped up in the left ventricular outflow tract also cause an outflow tract obstruction. This may also result from abnormally positioned papillary muscles. In case of left ventricular inflow tract obstruction, usually occurs rarely, and it may be from simple narrowing of the AV valve entrance into the left ventricle, which is associated with a marked right ventricular dominance in case of a left ventricular hypoplastic syndrome. In presence of an accessory AV valve orifice on the left side, it may result from cord triatriatum or a supravalvular fibrous rim. Conduction system, the defect in the atrioventricular septum of this usually displaces the coronary sinus ostium inferiorly and may appear to lie in the left atrium, especially when the ostium primum defects are usually large. And the AV node is displaced inferiorly caudally and it lies in the posterior right atrial wall between the orifice of the coronary sinus and the ventricular cusp. It is what has been termed as a nodal triangle. The bundle of His passes forward and superiorly from the node to the ventricular cusp, reaching it where the crust fuses posteriorly with the aortic valve annulus. It then courses along the top of the ventricular septum beneath the bridging portion of the left inferior leaflet, giving off the left bundle branches. The left bundle branches usually appear early when compared to a normal conduction pathway. As it reaches the midpoint of the crust of the ventricular septum, it becomes the right bundle branch, which continues along the crust a little farther before it descends into the muscle of Lancisi and the moderator band. The difference in the normal conduction system and the conduction system in the atrioventricular septal defect is the AV node lies more posteriorly, and the bundle of the left bundle branch usually occurs at the earlier stage just below the left inferior leaflet. This is the picture showing the location of the conduction system in the atrioventricular septal defect. The left superior leaflet, the inferior leaflet, right superior and inferior, and the middle is the cusp of the septum, and the coronary sinus and the AV node, which is lying, which usually should lie in the posterior part of the right atrium, and the penetrating bundle branch block of the left interventricular crust, and the division of the bundle branch occurs just below the left inferior leaflet. The major associated cardiac anomalies in atrioventricular septal defects are patent PDA, TOF, complete unroofed coronary sinus with a left SVC, situs ambiguous, DORV without pulmonary stenosis, additional VSDs, DORV with pulmonary stenosis, situs inversus totalis, total anomalous pulmonary venous circulation, a left ventricular outflow tract obstruction, a TGA, or other minor things are pulmonary stenosis isolated, supravalvular mitral stenosis, Epstein's anomalies, and coarctation and isolated dextrocardia. Minor anomalies are usually ASD, which is usually associated with a partial AVCD, left SVC without unroofed coronary sinus, partial unroofed coronary sinus, azygous extension of IVC, and the IVC to the left, lower left common atrium, presence of bilateral IVCs, right, and the other ones are very negligible. The pathophysiology, this is usually a left to right shunting type of physiology in the presence of an atrioventricular septal defect, unless a severe pulmonary vascular disease has developed or the important right ventricular outflow tract obstruction or pulmonary valve stenosis coexist. The shunt is usually at the atrial level, may be large or small or moderate. In such cases, the pressure gradient exists between the left. In moderate and small cases, the pressure gradient exists between the left and the right atria. And the presence of interatrial shunt with a mild atrial AV valve regurgitation usually resembles the hemodynamic changes similar to that of an isolated ASD. The left atrioventricular valve regurgitation is present. The left to right shunt becomes much larger. In fact, the regurgitating jet is usually directed from the left ventricle to the right atrium. The left as well as the right ventricular stroke volume is increased, and the marked cardiomegaly and heart failure usually develops in the early life. When the large interventricular communication is also present, the left to right shunt is large, and the right ventricular and pulmonary artery pressures approach or equal the systemic pressures early in the early period. And the pulmonary vascular resistance rises rapidly and usually importantly elevated after age of 6 to 12 months and sometimes even before. AV valve regurgitations are usually moderate in 20% of the cases and severe in 15% of the cases of a complete AV septal defects. And the most common site of this regurgitation is between the left superior leaflet and the left inferior leaflet, particularly at the base or hinge. The reason for the flow from the left ventricle to the right atrium, because of which the right atrium is dilated and there is no left atrial dilatation in such cases. If the regurgitation is sited elsewhere, such as into the left atrium might be enlarged. Symptoms and clinical findings. The partial atrioventricular septal defects without an intraventricular septal defect usually present in the first decade, and maybe later also. But with a mild AV regurgitation, they have an apical systolic murmur that is the differentiation from an ASD. With a moderate or severe regurgitation, symptoms appear early, progressing to the heart failure, requiring treatment in early infancy. Signs of an atrial septal defects plus an apical pansystolic murmur and a palpable LV apex is present in case of a moderate or severe regurgitation with a partial AVSD. In case of a complete AVSD, usually present in the first 1 year of life, usually in the early months with heart failure, which is not controlled medically. They present with tachypnea, poor peripheral perfusion, and failure to thrive. Occasionally, this heart failure is minimal in early in life, and the presentation may be delayed until some years, by which time there is almost always severe hypertensive pulmonary vascular disease and Eisenmenger complex that develops. On the physical examination, there is cardiomegaly, increased ventricular activity is apparent, and the S2 is fixed and split with loud P2 due to elevated PA pressures. The systolic murmur is usually audible over the left precordium from the shunt at the ventricular level and is increased in intensity near the apex when there is an important AV valve regurgitation. A mid-diastolic flow murmur is characteristically widely heard both over the lower left precordium at the apex the apex, secondary to the last diastolic flow across the malformed atrioventricular valve leaflets, depending on both the left to right shunt and any AV valve regurgitation. In the chest X-ray of an AVCT, usually in the partial AVCT, there is cardiomegaly with the right atrial, right ventricular, and the left ventricular enlargement and the prominent pulmonary plethora. Whereas in a complete AVCT, the cardiomegaly with marked plethora in infants and young individuals with heart failure. If they present in the later period of life, they present with features of severe pulmonary vascular resistance. On ECG, they usually prolong PR interval because of the posterior displacement of the atrioventricular node. And the right ventricular hypertrophy is usually more when compared to the left ventricular hypertrophy. And there is counterclockwise frontal plane loop, which is the superior QRS axis between the minus 40 to minus 150 degrees because of the longer course of the bundle branch and the early division of the left bundle branch on echo, allowing echo shows imaging of all the components of the complete endocardial cushion defects and an assessment of severity of these components. It is very important surgically. It gives an important surgical information can be gained through echocardiography by it can attain the size of the AST and the VST, the size of the atrioventricular valve orifices, the anatomy of the leaflets, the caudal attachments, the relative and absolute size of the RV and the left ventricle, balance of the canal, and papillary muscle architecture, which is 1 or 2 in the left ventricle. In apical and subcostal four-chamber view, it is useful in evaluating the anatomy and functional significance of the defect. The SD and VSD can be imaged during systole when the common anterior leaflet is closed. A combined use of subcostal transdural position and parasternal long axis in the mitral long axis shows the cleft in the mitral valve, the presence of bridging leaflets, the number of atrioventricular orifices, and atrioventricular valve leaflets, abnormal position of the anterolateral papillary muscle, which is displaced posteriorly from its normal position, and the number of papillary muscles. The subcostal five-chamber view gives an image of a gooseneck deformity. The subcostal and apical four-chamber view can image the caudal attachments of the anterior bridging leaflets to the crust of the ventricular septum, based on which the type of the complete AV canal defect by Rastrelli has been made. Natural history, the complete endocardial cushion defects develop heart failure within 1 to 2 months after birth, and recurrent pneumonia is common. Without surgical intervention, most patients, 80% of them, die by the age of 2 to 3 years. A child surviving up to 1 year of age without surgery has only 50% chance of living up to 5 years. 15% chance of living up to 5 years. In the later half of the first year of life, the survivors begin to develop pulmonary vascular obstructive disease in 90% of the cases. They usually die in late childhood or as young adults. Infants with Down syndrome are particularly more prone to the development of pulmonary vascular obstructive disease during infancy. Therefore, surgery should be performed during infancy. In partial atrioventricular septal defect, spontaneous closure of the defect does not occur. Congestive heart failure may develop in childhood earlier than secondum AST. The congestive heart failure is related to major MR or other associated defects. The pulmonary hypertension, that is pulmonary vascular obstructive disease, develops in the adulthood. Arrhythmias can occur in 20% of the patients, and 14% of the children of mothers with atrioventricular septal defects have congenital heart disease. Half have tetralogy of Fallot and half have atrioventricular septal defects. The cardiac cath and CINI are usually performed when there are major cardiac anomalies that coexist along with the atrioventricular septal defect, and when there is operability is questioned because of the evidence of pulmonary vascular disease. The surgical aspect, the main goal of surgical treatment of the atrial septal defect is directed towards the closing of the interatrial communications, which is virtually always present, closing of the interventricular communications if it is present, avoiding damage to the AV node and the bundle of this, and maintaining or creating two-component non-stenotic aortic AV valves. Repair of the complete atrioventricular septal defects with little or no bridging of the left superior and the left inferior leaflet, which is Rastrelli type A. A two-patch technique is generally used. After the right atrium is opened, the valve leaflets are often closed exactly as they are in systole. If instead they are open, then the saline is injected into the left ventricle to close them. At this point, the morphology of the leaflets, particularly their closure pattern, is studied, and the information is obtained to plan repair or of any regurgitation present or accommodate any lack of the left atrioventricular valve tissue. A fine 6 or 7 Prolin suture is placed between the left, the image shown in the B, the fine Prolin suture is placed between the left superior leaflet and the left inferior leaflet in their anterior aspect, and it is left loose. Then now the leaflets are allowed to open, and details of the atrial and the ventricular septal deficiencies and the interatrial and the interventricular communications are studied. The position of the coronary sinus is noted, and the course of the unseed AV valve, AV node, and the bundle of this is conceptualized by the surgeon for knowing of the anatomy. The leaflets are retracted as much as possible, and projected width shown here and depth of the atrioventricular patch is estimated. The planned suture line of the interventricular patch to the ventricular septum and the free wall is thus visualized by the surgeon. A polyester ventricular patch is trimmed to a flat rectangular pyramidal shape. The suture line may begin anywhere along the ventricular septum, but chordae of the right superior leaflet and the right inferior leaflet stay on the right ventricular side of the patch, and those of the left superior and left inferior, stay on the left side of the patch. And some may be cut if they interfere with the suturing, because the anterior edges of these leaflets will be sutured to the polyester patch. A retractor in the right inferior aspect of the common AV valve position, in which the base of the right inferior leaflet is sandwiched between the ventricular and the atrial patches. The suture line here stays well back from the crust of the ventricular septum and catches some of the base of the right inferior leaflet to avoid the bundle of his. These are the images which shows the above information. The left superior leaflet and the left inferior leaflet. There is a stay suture along the anterior portion of the left superior and inferior leaflet. And the lateral part of the AV valves are retracted, which allows us to estimate the size of the patch need to be made, that is the width and the length of the patch. And the D picture shows the image shows the ventricular patch is sutured with the right inferior lateral portion of the ventricle leaflet, and the sutures are away from the ventricular crust, and it takes a part of the right inferior lateral valve tissue to avoid damage to the bundle of his. The suture line for the interventricular patch is first completed anteriorly, and retracting the defect posteriorly and elevating the right superior leaflet to expose those aspects of the defect closer to the left ventricular outflow tract, as shown in the picture E. Width of the patch at the valve level will be less than the width deeper on the ventricular septal level. The left superior leaflet and the left inferior leaflet are precisely anchored to the ventricular septal patch with fine interrupted sutures or the mattress sutures, as shown in the F in the middle part. And the care should be taken to ensure that the left-sided apparatus at the patch is appropriately narrow so as not to create any regurgitation, and at the correct height so as not to provide any left ventricular outflow tract. Basically, if the width is more, it causes an AV regurgitation. If the length of the patch is more, it produces the left ventricular outflow tract narrowing. To provide accuracy, the previously placed fine stay suture joining the left superior leaflet and the left inferior leaflet is positioned approximately at the midpoint of the suture line of the between the ventricular crest and the left superior and inferior leaflets. The pericardial patch for closure of the atrial septal defect is trimmed to size, and a new suture line is begun with bites incorporating the pericardial patch, the left AV valve tissue at its junction with the top of the polyester patch, and the polyester patch sandwiching delicate between the left AV valve tissue between the pericardium and the fabric. Basically, the sutures are continued on from the lateral part, that is the pericardial stitch, from the outer part of the AV valve tissue, that is between the pericardium and the polyester patch. The initial suturing at the crust of the polyester patch can be done with pericardial patch folded towards the left atrioventricular valve. The conduction system is avoided by extending the pericardium to the right of the coronary sinus, leaving its drainage to the left atrium to avoid damage to the coronary sinus and the AV node. The competence of the left and right atrioventricular valve is next tested with saline injection. If necessary, small annuloplasty sutures can be placed between the left superior and inferior leaflets in case of any regurgitation, and between left inferior leaflet and the left lateral leaflet. The remainder of the pericardial patch is sutured inferiorly and then superiorly to the rim of the atrial defect, often also incorporating closure of the foramen ovale defect. Repair of complete atrioventricular septal defect with single patch technique. The right atriotomy is made as of two-patch technique, and AV valves are inspected. The saline is infused into the ventricles as per two-patch technique, and opposition points of left superior leaflet and left inferior leaflet is identified as the leaflets float up to the systolic portion. A fine same guy suture is placed for alignment and it is left loop between the left superior and the left inferior leaflets in the anteriormost portion of the interventricular septal defect. The later, each cut edge of the superior leaflet will be attached to the pericardial patch at its waist. The left superior leaflets are usually cut at the lateral part that is the bridging left superior leaflet away from the crust of the interventricular septum. for better viewing of the interventricular septal defect. The fresh or glutaraldehyde treated pericardial patch is trimmed partially after measuring the height and the width of the interventricular communication. Generally, the ventricular portion of the patch is attached to the right side of the crust of the ventricular septum using a continuous suture initiated at the deepest aspect, midpoint of the rim of the ventricular septal defect. This picture shows the incised left superior leaflet and the incised left inferior leaflet, because of which the below left interventricular communication is seen, and the appropriate measurement of the patch size is can be measured. Usually, precautions are taken as in avoided the two-patch technique to avoid the bundle of fish at the posterior inferior aspect of the ventricular septal defect. The AV valve leaflets, both the right and the left, are attached to the pericardial patch at appropriate level. As in two-patch technique, the central guy suture, which approximates the gap between left superior and left inferior, helps the positioning of the AV valves at correct height and midpoint on the single pericardial patch. The interrupted horizontal mattress sutures incorporate bites of the right-sided valve tissue, pass through the pericardium and end with the bites of the left-sided valve tissue, which is shown on the right inferior most part. The sutures enter from the right inferior leaflet through the pericardial patch and the left inferior leaflet. These are interrupted horizontal mattress sutures. And the small pledges of the pericardium may be used to buttress the sutures on the left and the right atrioventricular valve tissue. Several additional sutures may be used to complete closure of the gap between the left superior and inferior leaflets. The atrial portion of the patch is completed with continuous suture extending inferiorly and medially to the place of the coronary sinus on the left atrial side, incorporating the foraminal defect within the superior rim of the patch. Before completing the atrial septal patch insertion, the atrioventricular valves are tested by saline and saline infusion, and the annuloplasty is done as necessary. The approximate configuration of the pericardial patch for single patch technique, height and width, that is waist, is indicated by the dashed line on the image E, are usually critical because if it is the height and width are abnormal, it causes left ventricular outflow tract obstruction or aortic valve regurgitation. The modified single patch technique in 1997, Wilcox and colleagues reported direct suturing of the atrioventricular valves to the ventricular septum in complete AV septal defects with a small ventricular component. The advantage of these procedures are one, simplicity by avoiding a separate patch for the VSD closure, no division of the valve leaflets or chordae, and reduced operative time. Interrupted pleasure sutures of 5O braided sutures are placed on the right side of the interventricular crust, as in the ventricular septal suture line of the standard ventricular patch technique, and pass through the bridging leaflet superiorly and inferiorly. These sutures are then passed through the edge of the autologous pericardial patch used to close the atrial septal defect, and through a thin strip of dacron whose length is slightly shorter than corresponding ventricular septum, with the intent of producing a complete central annuloplasty of the left superior leaflet and the left inferior leaflet. These sutures are tied, and the remainder of operation proceeds as in singular double patch technique. This is the image that shows. The sutures from the right ventricular side of the septum with a pledget are passed through the leaflets and to the pericardium with a part of dacron graft on which is smaller than the size of the pericardium over the pericardium to hold the tissue, to hold the sutures. And the rest of the technique is similar to that of a two-patch technique, which is along the rest of the sutures are lying along the atrial septal defect, rim of the atrial septal defect, incorporating the coronary sinus. The repair of complete or partial atrioventricular septal defects with the moderate or severe left ventricular AV valve regurgitation. In the repair of complete atrioventricular septal defects, the primary determinant of left AV valve incompetence, particularly when preoperative AV valve regurgitation is moderate or less, and accurate sizing of the ventricular patch is important to produce an annuloplasty effect and avoiding elevation by patch of the left superior and the left inferior leaflet above their pre-repair level. If the size and placement of this patch has been imperfect, this should be corrected. If the patch and its placements are considered optimal, the basic options depend on observations about one location and mechanism of regurgitation by filling the left ventricle with saline. If even then there is a major leakage, and the leakage is between the left superior and inferior leaflet, the cleft is partially or completely closed with the interrupted proline sutures or braided sutures, which may be reinforced with a small bovide pericardial wedges if the leaflet tissues are fragile. If the leakage is in the central or at the commissures between the left superior and inferior leaflets, lower leaflets, or between the left lateral and the left inferior leaflets, annuloplasty sutures are done. Annuloplasty sutures can be taken to reduce the annular circumference. In cases of marked central leakage with an enlarged orifice, a more extensive annuloplasty of the left lateral leaflet and its commissures using a PTFE band has been reported. If the leakage is through the accessory leaflets, they may be partially closed. When the repair is completed and leakage is trivial or absent by saline injection, the remaining orifice is sized with Hager dilators and usually a measuring diameter yielding of Z value of more than -2 or greater is generally adequate to avoid valve stenosis. In the presence of persistent, moderate to severe residual regurgitation, particularly in the reoperative settings, despite the manuals described above, two or more radical techniques may be applied, which are when the severe central regurgitation, particularly in the presence of leaflet prolapse and left lateral leaflet and the reconstructed anterior leaflet may be approximated with a pledgeted master suture, creating a double orifice valve. To avoid physiologic stenosis, care must be taken that the orifice of the reconstructed mitral valve is somewhat larger than normal, probably a Z value of 1+1 or larger before placing the approximation suture to avoid stenosis. An additional procedure in the presence of leaflet deficiency that has reported short and midterm success in patch augmentation of the neo-anterior leaflet is leaflet augmentation technique. Using the glutaraldehyde treated autologous pericardium for severe dysplastic left atrioventricular valves. The picture 8 shows radial incisions adjacent to the annulus is made in the superior and inferior vigil leaflets from the commissure to the commissure. In the B picture, the abnormal secondary chordae to the ventricular side of the leaflet are divided. In the picture C, the patch of the autologous glutaraldehyde treated pericardium is sutured in place, augmenting the anterior leaflet. And this causes a tension-free closure of the cleft is now possible. Palliative procedures, PA banding in early infancy is no longer recommended unless other associated abnormalities make complete repair a high risk procedure, such as those with unbalanced AV canals. The mortality rate after PA banding can be usually as high as 15%. The overall mortality rate post-surgical repair of the atrioventricular septal defect is 3 to 10%. And the complications include mitral regurgitation. It may become persistent or worsen 10% of the time. A sinus node dysfunction resulting in bradyarrhythmias may occur. And although complete heart block occurs usually rare in less than 5% of patients, it occurs most frequently when the mitral valve replacement is required, up to 20% of patients. The first degree AV block is seen in 50% of patients post-repair. Post-operative arrhythmias occur and are usually supraventricular. The risk factors for defining the mortality post-repair in an atrioventricular septal defect are demographic variables due to prematurity, young age, and clinical variables, high NIHA class grade, greater severity of preoperative AV valve regurgitations, and the morphological variables, presence of a single papillary muscle, accessory valve orifice, major associated cardiac anomalies, severe left ventricular hypoplasia. Surgical variables, earlier date of operation, interaction with age. Post-operative variables are severe post-operative left atrioventricular valve regurgitation, absence of sinus rhythm, higher left atrial, right atrial, or the pulmonary arterial pressures. Reoperation variables for pacemaker, for VSD, and for left atrioventricular valve regurgitation, the risk of mortality is high. Thank you.
Are you finished?
Yes, sir.
Navya, I'm sorry. I lost you completely after the first 5 minutes. This is totally theoretical thing. It looked like you have just taken a textbook, cut and pasted the whole thing into the slides. There was no way that we could understand what you were talking about. And especially for people who are going in for an exam, I'm sure you yourself may not be able to reproduce this after 3 days. So it was completely, totally theoretical. In this, after you define what an AVCSD is, you should have talked a little more about the classification, put pictures, all these things should have, you should have collaborated with pictures on your slides. And the rasterly classification was important, the different types. Then the most important thing in an AVSD is the conduction bundle, how it is different from a VSD and where it goes. So that is important for you as a surgeon. Then the diagnostic features, the classical diagnostic feature. You talked about ECG, echo. There was not a single picture of those things. All right. How to differentiate which is which, what is the partial AV canal, what is complete AV canal. We didn't understand that part of it. Then when it comes to treatment part, you should have talked about the timing of operation. When do you do what procedure? Especially closure of the ostium primum, especially the technical details. Many people close the ostium primum in such a way that the coronary sinus is directed to the left atrium. That features you should have talked about in detail with diagrams. Then also again the single patch technique and the double patch technique. When do you use what is the thing? This should have been highlighted in your presentation. And if I may say, most of these presentations have already been done by your seniors, right from Varun's batch. If you have taken the trouble to go through the archives, I hope it is there somewhere, and then seen previous presentations, you could have picked up some things from there and then improved on those presentations instead of just taking it from a textbook and just copy pasted the whole thing. What was your reference? Where did you get all this material from? Huh?
Parks and Kirkland, sir.
You should have taken a little more this thing on there, much simpler books to read. Stark Tival or the operative textbooks give you a much better idea for you to understand this. This is entirely theoretical. Sir, you have comments to make, sir?
No, this is a condition which used to be called the endocardial cushion defect earlier. Then it became AV canal. Now the most commonly used term is the atrioventricular septal defect. First or complete. You didn't say much about the presentation. The partial AV canal defects present like an AV later on, whereas the complete AV canal or atrioventricular septal defect, they present early, about 2 months after birth, because the normal pulmonary vascular resistance at birth, the girth at the end of 2 months or so. That's why severe type of atrioventricular septal defect, they become very symptomatic at 2 months. And ideally, they are operated, they are given medical treatment, and then they are ideally operated within 2 to 4 months. The other thing is, you didn't say what the presentation. Because many of these patients with a large ventricular septal defect part of a complete AV, atrioventricular septal defect, present early with a left heart failure, with breathing difficulties, with feeding difficulties, with tachypnea, and growth retardation. That's a usual presentation. That's all signs of overflow, and because of the overflow into the pulmonary tree, they present with a recurrent respiratory tract infections. This is the usual presentation. Such cases present within 2 months and they have to be operated 2 to 4 months. Whereas if the passive IV canal in the hospital policy is to operate around 2 years. And you said actually the incidence of this congenital cyanotic pathology of virus about 2%, whereas in Down syndrome 70%. And if you take all the Down syndrome patients, 40% of them may have a Avsd. That is the trisomy 21 of Down syndrome. 40% of them may have, and in those people, the presence of a severe pulmonary vascular resistance is much earlier. Because most of the Down syndrome, it gets repeated respiratory infection or as well as lower. And usually they go into severe pulmonary vascular disease earlier. The other thing you all described all the anatomy very well, but you didn't describe what is the balanced AV canal, what is the unbalanced AV canal. Have you any idea what is the balanced AV canal and
In that, unbalanced AV canal is either the hypoplasia of the left ventricle and the atrioventricular orifice is directed towards one ventricle.
very good. That means the atrioventricular orifice is directed mainly to the right side. The left ventricle becomes hypoplastic in such cases, or vice versa. And so the operations for each of them is difficult. If it is a hypoplasia of the left ventricle, the operation is a Damu's-Case cancer operation. Where the pulmonary artery, prominent one, is anastomosed to the side of the aorta. And whereas if it is right hypoplasia with a major orifice to the left, then they go into VDG and later on frontline type of correction. And you also said about 10, there may become other associated features in Avsd, like a PDA 10%, tetralogy about 6%. Some books say 10%. That's classically we call a canal type of tetralogy, where the ventricoseptal defect is posterior paratricuspid, and if a patient comes with a TOF, the combination of ABSD and TOF, the treatment in the initial stage, the pulmonary stenosis is significant, we do a BT shunt in infancy and do a total correction at about 3 to 4 years. And the mortality is higher, about 10%, they say. The mortality of ABSD correction, you also said about 3 to 10%. Whereas previously, the treatment first treatment, palliative treatment used to be PA binding, but you said also the PA binding itself has got 15% mortality. So nobody does PA binding, they rather go for a one-stage correction of the atrioventral CT. We all used to do two-pass technique, it's very important to have a two-pass technique, either a polyester or a PTF, a Gore-Tex shaft is taken for a VSD. And then it's important to avoid the bondage. You said all, whether it's a partial or a complete AV defect, the coronary sinus is displaced inferiorly. And the main conduction bundle goes near the crest of the ventricular septum onto the left-hand side. That's why the pictures you see, the interrupted projected sutures are taken on the right side of the ventricular septum, and in the two-patch technique, the curved part of the patch is the sutures go through them. They come up, the sutures are taken, the superior leaflet either divided or with a cleft to that. The most important thing is the superior bridge, I mean the
Bridging
leaflet.
legs.
And then if you do a two-pass technique, the polyethylene or PTFE graph, then you put a pericardial patch for that, and very often people divert the coronary signs to the left side. Then came the single pass technique. You didn't tell me what the surgeons do in NH. Whether it's a double patch or a single patch.
Double patch technique.
Double patch. Following job,
I have not seen.
following job was trained by Graham Mann, who popularized the single patch technique in Australia, and it's very commonly practiced nowadays. And then the usual diagnostic things you said, the ECG, superior, with the left severe left axis deviation -40 to -150, the vector, superior vector, and clockwise, anti-clockwise. And then most important diagnosis before the echo came was left ventriculogram in the frontal view, which gives the classical loose neck, the narrow, long. That's because of the deficiency of the inlet portion of the ventricular septum. It gives a long, narrow, like a gooseneck. Now, in echocardiography, the subcostal white chamber view gives exactly the same thing of a gooseneck deformity, long, narrow neck. So that's a diagnostic, important to diagnostic left ventriculogram, which is not done nowadays, but white chamber, the subcostal white chamber view, which gives exactly the gooseneck deformity. I think a lot of people don't know a single pass technique. And you must be very thorough with rasterly A, B, C classification. Important thing is to have a
You should,
correction at a earliest possible. 4 to 5 months in a complete AV plan. At present, at 2 months, give some medical treatment as early as possible.
no, you should have probably did a little more reading. There are journals, seminars in cardiovascular surgery available on your clinical key, pediatrics seminars as well, and then some amount of operative textbooks. So then you will understand what it is all about. Kirkland is very difficult to understand. Much simpler to read some operative atlases or things like that, wherein you will get diagrams, you will understand it better, and then you could probably have made a better presentation.
The textbook, my own part, gives most of the details of what you want, what the incidents, what is the natural history. but it doesn't give the operative details.
There any questions from anybody?
What exactly do you mean by atrioventricular septum? Which is the atrioventricular septum? Anybody?
Atrio.
Yeah. What exactly the anatomical part of atrioventricular septum? We used to have difficulty in understanding that. But with the development of echocardiography, if you see an echocardiography clearly, you see the ventricular septum, the attachment of the septal leaflet of the tricuspid valve is at a lower level. The attachment of the anterior leaflet of the mitral valve to ventricular septum is at a higher level. So much so, in that small area, there's an area where left ventricle is directly coming in contact with the right atrium. That's exactly what is called the atrioventricular septum. That's what, if there's a defect there, that's what you call a Garbodi defect, where the blood is shunted from the left ventricle directly to the right atrium. Because that area, there's a direct communication between the left ventricle and the right atrium. That is atrioventricular septum. Because of the difference in the level of attachment of the anterior leaflet of the mitral valve and below the septal leaflet of the tricuspid valve, that area is related to the, you can see the membranous septum, it's related to the bundle. So that's the importance of that. Atrioventricular septum.
Is there any questions? Any questions from the audience or participants? Most of you have logged in and gone to sleep, maybe just like me.
I don't see many seniors coming.
Sorry, sir?
I don't see many seniors taking part in this.
Yeah, I mean, nobody questions, nobody takes part. There is no active participation. Only the presenter will do something, and then that's it. And then that day is over, finished. Until the next day your presentation comes up. Till then, you don't have to bother. I mean, this is this.
That's why we said give a month feast, so that each one knows what is going to be the presentation next year, and at least read something so that you can easily understand what exactly is going on.
Yeah, that is why we need a timetable, and then the timetable should be put up so that you have enough time to read through different articles, different things to make a presentation. Anyway,
it's so easy now because everything is at your fingertips. You remember our time you had to go to library and refer so many books to find out some books. Very difficult, now. It's all at the fingertip, everything you can see. All these young people are experts in. I find it very hard to search and find some.
I'm sure if you went through clinical key and picked up some of the issues of seminars, I'm sure there will be a full issue on only AVSD in that series. So you could have got a lot more material, a lot more this thing, and then concise it to one presentation. So see, the whole idea is that you should be able to reproduce all these things in an exam. One. Second, to understand the concepts. When do you do what? what are the pros and cons of a single pass technique versus a double pass technique? When do you choose what to do, when to do, and how to do? And what are the complications that you can encounter, and how do you tackle that? That is all that is necessary for you to at this stage. At least if you know, even if you don't know how to treat it, if you know the principles and the concepts, that is more than enough. And you should learn to put in more diagrams so that you will remember it better.
Yes, sir.
Okay, thank you. Thank you, sir.
Thank you.